Start the examination by washing your hands. Greet the patient and ensure a chaperone is present. Obtain adequate exposure, initially ideally to underwear, to assess gait. Ask the patient to take a few steps, turn around and come back. Comment on the use of aids, such as a stick, frame, brace or shoes. Now perform Trendelenburg's test. Stand opposite the patient and hold out your supinated hands. Ask the patient to place their hands on yours. Perform the test on the good leg first, asking the patient to bend the knee of their affected leg. Normally the weight-bearing hip is held stable by the abductors and the pelvis rises on the unsupported side. If the weight-bearing hip is painful or unstable, the pelvis will drop on the unsupported side, and this would indicate a positive test. This should then be repeated on the other leg. With the patient standing, inspect from the front, back and sides of the joint, looking for any scars, swellings, asymmetry, deformity, erythema, sinuses and muscle wasting. Now lay the patient on the couch, supine. We will demonstrate the remainder of the examination on the right side. However, you must remember to examine both sides. Ensuring that the patient is not in any pain, feel for temperature changes with the back of your hand. Now palpate for pain, maintaining eye contact with the patient. This should be done systematically, starting with the greater trochanter, femoral head, adductor longus, and remember that the ischial tuberosity should also be palpated posteriorly. Now palpate for crepitus by rotating the hip medially and laterally. Crepitus may suggest osteoarthritis. Assess the inguinal lymph nodes for lymphadenopathy. Now measure leg length. Start with apparent leg length, measuring the distance from the xiphisternum to the medial malleolus. Measure the contralateral limb. Now measure true leg length. First, squaring the pelvis, aligning both anterior superior iliac spines in a horizontal plane, and demonstrate this by placing your elbow and hand on each anterior superior iliac spine. Measure the distance from each anterior superior iliac spine to corresponding medial malleolus. Discrepancy indicates shortening of the affected limb, and this should be isolated to one of the following levels. First, flexing the hips and knees to 90 degrees and aligning the medial malleoli. Measure the length of the femoral neck by placing a thumb on each anterior superior iliac spine and middle finger on each greater trochanter. Imagine a line drop vertically down from the anterior superior iliac spine and a second line extended horizontally from the greater trochanter. Place your index finger at the point where these lines cross to form Bryant's triangle. When the distance between the index and middle finger is shorter than the contralateral side, this indicates supratrochanteric shortening. Now measure the femoral shaft. Shortening is demonstrated as the knee of the affected limb lies proximal inferior to the knee of the good limb. To assess shortening of the tibia, this should be demonstrated as the knee of the affected limb lies distal inferior to the knee of the good limb. Note that if there is an initial adduction deformity, measure true leg length by abducting the unaffected limb symmetrically to the affected limb. Movements should ideally be tested actively, passively and against resistance with the pelvis square. We will now demonstrate these movements passively. Start with Thomas's test to unmask fixed flexion deformity. To perform Thomas's test, the patient should be lying flat on the couch. Place your left hand under the patient's lumbar spine. Ask the patient to flex both hips and knees fully to obliterate the normal lumbar lordosis. Ask the patient to hold their affected limb with both hands, and with your other hand holding the lower leg or ankle, control full extension of the limb to be tested. Full extension is normally achieved with the lumbar lordosis still obliterated. If there is a fixed flexion deformity, the patient will arch their lumbar spine and the lumbar lordosis will reappear. Pressure will also be relieved on your left hand. Now test the movement. Starting with flexion, external and internal rotation, abduction, adduction, noting that if there is an initial adduction deformity, place the unaffected limb abducted off the side of the couch and adduct the affected limb in the horizontal plane until the thumb appreciates movement of the anterior superior iliac spine. Extension may be performed with the patient on their side or prone. Note that if Thomas's test is positive, do not test extension. To finish your examination, examine the joint above and below, assess distal neurovascular status, ask whether patient's symptoms affect their quality of life and sleep, help the patient dress, order appropriate radiographs, and thank the patient.